Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show, bringing another really awesome guest for you today. On the show today, we have the honor of being joined by Peter Basica, founder and chairman of 360 Smarter Care. They are an independent AI-driven healthcare company, ultimately redefining how self-funded employers manage healthcare cost and population health. And under his leadership, the organization applies behavioral science, AI, a really deep understanding of human empathy to deliver these personalized one-to-one engagements at scale, improving health outcomes while ultimately focusing on reducing costs. Before launching 360, Peter spent over 3 decades building and leading various high-performance organizations across industries, including insurance, automotive, marine, manufacturing, and financial services. He's also the founder previously of Silver Bullet Partners. He spent a couple of decades there as President and Senior Educator, working directly with a variety of C-suite executives on sales performance, leadership development, executive coaching. Peter's also the founder of Digital Consumerism, which is a really interesting platform designed to help individuals maximize financial wellness and ultimately protect digital assets and make smarter everyday decisions across banking, healthcare, travel, and cybersecurity. He's also deeply committed to service, founded organization Remember Our Military, which is a volunteer-driven nonprofit ensuring that active duty service members and veterans don't spend holiday meals alone, serves on numerous advisory boards as well. A lot of really interesting topics to get into today. An honor to have him with us. Peter Basica, welcome to the show.
Thank you very much. Listening to all that, I think I need to find the Fountain of Youth or something. I must have been doing this too long.
Well, you've been doing a lot of interesting things, and what's happening right now is equally interesting. And I look forward to discussing rural transformation and the health bill and everything else. Before we do any of that, I'd love to hear just a little bit more about you, because clearly in your career has been all about systems change and human behavior and everything in between. Just tell us a little bit more about you, because you got an awesome background, I got to say.
Well, thank you. It didn't dawn on me until about a year ago where that came from. And I've always been a political junkie. I was watching the returns for Robert Kennedy in the California primary from Chicago, and actually saw him assassinated live on TV. But one of the things that he said so frequently was, some people see things as they are and ask why. I see things that never were and ask why not. That's where this all came from. And I really didn't connect those dots until a year ago at the most.
And it's rather an opportune timing, because we have the big beautiful bill. It was signed into law on July 4th of last year, and a very important component of that, which we really want to get into today, is the Rural Health Transformation Fund. And this is $50 billion over 5 years to ultimately really rethink what rural health is all about, really transforming it. Take us a little bit into rural health. I mean, it's all about transformation and stabilization, and we have a lot of problems right now in the rural healthcare system in terms of hospital closures and primary care disappearing, and a lot of workforce shortages because doctors and nurses and nurse practitioners don't want to work in certain areas of the country. What's going on in terms of rural healthcare, and why are we in this sort of crisis of structural collapse in 2026?
The why goes back to NAFTA. And when NAFTA was passed with Bill Clinton, the rural areas started to falter, and they've been faltering ever since. Without getting into a political debate about tax and trade, our rural areas have just suffered and suffered and suffered under policies for decades under both party rule. With that in mind, there are solutions, and the solutions have to be hybrids of technology and going back to the way medicine was practiced in the 1930s. Think of it this way: in a rural, underserved area of our country, a 4-year-old wakes up, her ear hurts. She wakes her mom. Mom gets out of bed, they go into the kitchen. Mom opens up her FDA approved remote diagnostic kit. Within minutes, she's connected to an on duty physician assistant that she actually knows because it's part of a virtual primary care practice. The physician assistant guides the examination. They take the instrument, look in the ear. The PA says, tilt it up, tilt it down, tilt it. They see exactly what they would see if they were in the office. And we can go from an otoscope to a pulse oxygen sensor to EKG with the same device that's in home. And without leaving the home, the doctor can be anywhere and provide the diagnostic care that they need. The flip side to that is, Ira, your phone rings and it's Pat from your primary care physician's office. And Pat says, Ira, your blood sugar has been off the chart the last couple of days. What's going on? And you replied one of two ways. Well, I'm on vacation in Puerto Vallarta. I'm by the pool, my fifth pina colada. Oh, my Lord, bad plan. Stop doing that. Converse is, I'm doing everything I'm supposed to, and it just keeps going up. Ira, let's get some blood work done and figure this out before something bad happens. We'll work together on it. Proactive medicine remotely. That's the solution to our problem. It's not trying to save a hospital that can't be saved because the demographics aren't there to support it.
And continuing along that line, and we'll get into 360 in a moment, but when we talk about the transformation fund and these $50 billion, take us through just a little bit of what the dynamics currently are with that, because I was taking a little look at sort of the current allocations for 2026, and I saw the largest is at Texas at around $280 million. Jersey is at the bottom near 147. So these are substantial funds that are going out to the states. Walk us through a little bit, because clearly the funding is allowed to be used for what you're talking about in terms of telehealth, in terms of telemedicine and enhanced data systems. Walk us through sort of, how the funds are currently dispersed. I know CMS is involved, and a little bit, if you don't mind just saying, I've seen a lot of similar themes, whether we're talking about Texas or Alaska. Walk us through a little bit of what's been happening so far since the bill was implemented in terms of some of the states.
We have been very fortunate to be involved with several states early on as their Department of Health and Human Services, Department of Health, started to assemble their applications to send into CMS to tap into the 50 billion. The way that's being allocated is pretty straightforward. It's based on the size of your rural population. So a state like New Jersey, while it's the most populous state, they have a very limited rural population. Rural population is defined, I believe I'm right when I say this, at 500 people or less per square mile. So hard to find rural in New Jersey. Having said that, there are rural residents in New Jersey, and there's something else that goes on, which are healthcare deserts within cities. You know,
Hmm.
I live in Manhattan, and while Mount Sinai has a huge presence all over the city, particularly in Harlem, there are areas in Harlem where there's no primary care. Uh, so the same problem that exists in rural does exist within our cities. With that said, New Jersey is actually leading the nation. They have moved decisively, quickly, and actually put what I would believe to be excellent reporting controls into their RFP requests. So kudos to New Jersey for being proactive and doing a great job. Most of the other states have yet to even publish requests for information, let alone RFPs.
Gotcha. Gotcha. Now, when it comes to your organization, your major customers are self-insured, self-funded employers and health plan sponsors. And here again, for our non-US listeners, we're talking about companies that today in 2026 directly pay the healthcare costs of their employees and their dependents, and as a result take on all the financial risk. Obviously, there are certain benefits to doing this in terms of mandates and taxes and all of that. But just talk about what it means to be self-insured in 2026 in the United States, and a little bit of sort of, because I know that's a big chunk. I mean, something about like 67% of workers now, they still within employer-based healthcare coverage in that context. Talk a little bit about this profile of your target customer here.
First of all, it's a real pleasure uh, speaking with someone like you who has done the research, and we can have a coaching conversation about this. The way 360 started literally is when most people would have retired. I talked to my wife and said, we've had fun, we've done a lot of things, we could retire, but we haven't really changed anything. And the legacy that I want to leave our daughters is that there's more than just operating businesses and making money. And honey, I have an idea of how to change healthcare, and I want to start 360. So we did. And what you've listed that we're doing now pays the bills. What we want to do with rural healthcare is our legacy and will change the way healthcare is delivered. I presented a solution about 18 months ago at the University of Illinois to the Carle Illinois College of Medicine. It is a unique institution because it's founded on the premise that innovation, AI, technology, engineering are the future of medicine. The bulk of their students have an advanced degree before they apply to medical school in something like artificial intelligence or structural engineering or you get the gist. They're creating the leaders of the future of medicine. They are the antithesis of the oldest medical school in the United States, which we don't need to name and say anything negative about them. But the care system we have today is their legacy. They built this to say, we're not doing it the best way possible today. That's really tough when you built the system. So you have ingrained hundreds of years of institutional knowledge with many, many medical schools. On the flip side, we have what we refer to as conglomerate care. When you look at the list of investors, the big investment companies, and you go across the spectrum of healthcare, they're all the same. It's basically the same five companies, whether we're talking about owning pharmaceutical manufacturing, buying physician practices, imaging centers, hospital, and everything in between. Then it gets worse because the big healthcare companies are owned by the same people, the health insurance companies. You go out, you set up your own self-funded, self-insured health insurance program for your company to try and save some money and take better care of your people. And you hire a third-party administrator who is part of conglomerate care. So as you tried to get to that independent level, you're still locked in the system. If a CPA, let's put it this way, any publicly traded company has internal accountants. They have a CPA, and then they have an audit firm that has nothing to do with their business whatsoever. When you turn in your health insurance claim, there's a great possibility that your insurance company or third-party administrator, one of the sister companies, holds equity in the claim that they're auditing. You'd lose your CPA license in a heartbeat. And this is routine in our country. We have to break that system. When I've presented these solutions to different health institutions, the faculty, the deans, the administrators sit there, shake their heads and say, yep, these are the problems. Here are the solutions. Yep, those are the solutions. Well, if you know the problems and know the solutions, why haven't you fixed them? One answer is, we don't want to take on these vested interests. And the other answer is, there's a short-term funding gap when you implement new technologies that won't be covered by Medicare, Medicaid, or private insurance of any kind administered by a TPA. So there's a funding gap. That's what RTH should be used for, is to fill that funding gap, to be able to put that FDA-approved diagnostic device into your home, to be able to pay for our services, which literally will take data dumps from, say, a continuous glucose monitor that shows your blood sugar level throughout the day. All that information sits in a lump. You can ask your doctor and share it with your doctor, but somebody's got to comb through it. We look at it and say the way this should work is the physician should say, for Ira, who has the killer cocktail, he's diabetic, he's hypertensive, and he's overweight, which obviously you're not, but huge percent of our population fights that battle. But if you are 30 years old, the relevant clinical measures are different than they would be if you're 12 years old or 60 years old. So we allow the physician to set that level for Ira and Joe and Mary and Pat. And we only send the information to the physician's office when the metrics they set for the patient have been exceeded. So we take data dumps and turn them into actionable items. It's proactive medicine, which we simply don't practice today. We've got biohackers, we've got this. They're this much of a sliver of the population. Right. If you are suffering from being overweight and diabetic and have high blood pressure, you wake up in the morning miserable. And then the doctors and nurses stare at you and say, well, why didn't you exercise more? Because I'm sick. I feel we've got to address this whole thing. Diabetic education programs that every health plan has run 6 weeks, 8 weeks, 12 weeks, and then they're gone. Well, we fixed your lifetime behavior in 13 weeks. Who are we kidding with this nonsense? Our digital therapeutic, whether it's a hypertensive person or a diabetic or whatever, is a lifetime. We start you out at 101. After year 1, you move to 201, to 301, to 401. It's continuing to broaden and expand and empower the user to take control of their own health. Sorry, this is my passion. This is the mission of our company, and I'll talk all day about this.
No, it's great, and I want to keep going on this route because it's so core to what you've created there at 360 Smarter is that's actually it's sort of an interlaced set of platforms here. And I thought we could just we could go from where we just were. We can start off, and I know, as I mentioned, core to a lot of your work throughout your career has been this ability to support proper behavior. So I think the best place to start out would be in the first platform known as Behavioral RX. It's an AI-driven personal engagement component. So it crafts the personalized plans, and it takes into account sort of the models to help motivate, to activate, to sustain adherence. You made me hypertensive, diabetic, and obese. That's cool. It's fine. So I mean, sort of take me in that profile, put us out there in a rural health desert, and talk a little about how I would use behavioral RX.
Oh, absolutely. That is based on a acronym that we call MILD. It stands for micro learning and micro doing. People change their behavior incrementally. So just in that particular instance, we would know that you need to be eating a specific type of diet that is going to address your weight, your hypertension, and your blood sugar levels. So as we get to know you and the information goes back and forth, not everybody does this, but an example would be you go shopping at the local grocery store Thursday evening at 6:30 because you know it's empty. Once
Mm.
we find that out, we will provide for you a healthy recipe for your specific health conditions, with the idea being that if that recipe appears on your phone through a text message an hour before you say you're going shopping, we're going to nudge you to eat one extra healthy meal every other week or two a month, whatever. We just keep nudging, nudging, and nudging. Uh, our our virtual primary care model, which all this integrates into, has a healthcare coordinator. Insurance companies offer the services of a healthcare coordinator for complex cases, for really sick people. But honestly, their job is to minimize the insurance company's expense, not necessarily your health. By embedding that function in with the primary care team, their only function is to help you get healthy. So you get a live health coach, so to speak, in addition to us nudging you twice or three times a week with a message. Every one of our users gets what amounts to a homepage. And on that homepage, on the top third, it asks you how you are. Because if you're not positive up here, nothing we send is going to matter. So if you tell us you're happy, you might get an irritating song from Farrell singing happy to reinforce that mood. If you say you're really struggling that day, you're going to get a message along the lines of, you're not alone. This too shall pass. Here's an article. Here's a video. Here's an audio that might help you get through the day and make it a little better. Second third of your page is just your general health and whatever your conditions are. So that information is curated to that. The bottom third of your page is where you put your favorites so that when you need them, they're accessible to you. When you put this together with remote patient monitoring, where we ask you to get on the scale once a week, where we track your blood pressure, where we track your blood sugar, now this whole system comes together in a real care system as opposed to a doctor here and a program I bought to lose weight. It needs to be a team. There's an expression, it takes a village. Yeah, your health does take a village.
Let's keep going with that, because you now with behavioral RX, you've modified my behavior. I'm now motivated. I'm taking my metformin and my Ozempic and my ACE inhibitor. I'm doing okay, but I need I need some care. And along comes 360 Direct Care now, which is this virtual model. And you've been talking a lot about diagnostics. I love the principle of remote diagnostics and monitoring. I only see my doctor once, here in Philly, once a year or twice a year now. But as you know, my body changes every day. My blood sugar does this, my weight does that, my blood pressure does the other thing. Bring in 360 Direct Care now and put me back out there in the health desert and take care of me a little more.
Absolutely. Think of it this way. If we built a brick and mortar family practice and wanted to take care of 4,000 patients, we'd need two full-time primary care physicians and then staff on down from PAs on all the way down. We need tech support built into that practice. We need the care coordinator built into that practice. And we need to staff for 24/7 operations.
Mhm.
If you walked into the clinic, you'd see Dr. Pete. If you opened your device, you see Dr. Pete. If Dr. Pete's not there, you get the partner, Dr. Deb. If the doctors aren't there, it's a PA. But it's people that you get to know over time. There are going to be occasions where you need to be in that physical practice center. There's no question about that. We can't duplicate touch remotely. That we're not there yet. So our concept is to partner. For example, in Champaign, Illinois, there is a hospital affiliated with the medical school, and there are rural patients that they serve. But those rural patients have a 30-minute or an hour or a 90-minute drive. If we can touch them remotely in between, we can make them more comfortable. But one of the easiest ways to control the cost of medical care is to minimize unnecessary urgent care visits and emergency department visits. Why do I mention urgent care? I believe the number now is either 39 or slightly above that percent of urgent care centers have been purchased by hospitals. And they can now charge as an emergency room because they're affiliated with the hospital. So you, as a cost conscious healthcare consumer, make the choice to go to the urgent care instead of the emergency room because emergency room is the most expensive medicine, period. And you still get billed like you went to an emergency room.
Mm-hmm.
Now you're rural and you have we need to eliminate that. We bring the clinic to your house. It saves you time, it saves you money. And why should you be bringing yourself for a well physical into a room filled with sick people? I used to joke, we live in New York, about the grocery store. Everybody was being so careful about COVID. And then I'd go to the grocery store because I had to get food for the family, right? So I'd charge into the COVID distribution center and buy my groceries.
No, yeah, it's
Waiting rooms are the same thing. Let's get the people out of the way. I'll digress for a moment. My biggest frustration coming out of COVID is that the one thing that I think people should have learned, and it wasn't pushed: when you're sick, stay home.
yeah, yeah.
Could we just use a little common sense? Don't come to the office and be that. You can Zoom in. You can, and if you're a factory worker, I understand you can't do. But why do you want to make everybody on the line sick? You're sick. Stay home.
There, you have another part of the application. It's called 360 Smarter Search, and this is all about using these tools to ultimately identify the lower cost providers for various outpatient services, whether it's imaging, urgent care, lab work. I'm a pharmacist by undergraduate training. I'm sure pharmacy is a major part of that. Well, whether I don't know how many pharmacies are out there in the health desert, but talk a little about this because I mean the cost. Obviously, it's so very important for our employer in their cost containment goals, and but giving some transparency, the transparency has not always been there, let's just say, of what, one service costs versus another, what this generic costs versus another, and so forth. Take us into 360 Smart Search, because I think this is another really interesting part of the portfolio.
The easiest way to look at it is if we just did a crude separation, we would take off the list of approved providers, your in-network providers for any health insurance plan, where the urgent care center is attached to a hospital, because we know they're going to charge 2 to 3 times more for the same care as one that is independent. So essentially what we're doing is culling out the most expensive in-network providers.
Mm-hmm.
Over a period of time, and we don't have a client like this, I wish we did, we would actually be able to curate that list to not only who are the most cost effective, but we could cross match that to those with the highest level of consumer satisfaction and gold star the cost effective places that delivered prompt care that the patient, the user, the consumer rated as, yeah, this is a 5-star place. We need access to the information, which is not always easy to get from the insurance companies, because they want you to go to that place they own.
Yeah. It's no, it's a really elegant set of offerings, and it's quite integrated. And we talked about predictive AI and behavioral science and the digital therapeutics, and now we go into cost containment and analytics. What I mean, I noticed you have a rather extensive set of collaborators and research partners from Brown University, NYU. You got Rutgers on here, Yale. Talk about a little bit what you're doing with some of these groups, because obviously this is a system that's constantly being refined, and you're going to be adding to it and modifying things. What do you do with some of these partners? Because they're all quite impressive, and if you could take us into some of the stuff that's not confidential, love to hear about it.
Absolutely. You've just given me the opportunity to talk about our sister company, our brother company, which we do not own, although we do have some joint ventures with them. It's a company called Gomo Health. Gomo Health was founded by Bob Gold. I met Bob Gold years ago, and it was actually kind of interesting. I booked the appointment through a gentleman by the name of Gary Pollock, sat down with Bob for lunch. About halfway through lunch, Bob looks at me and he says, I'm enjoying the conversation, but I'm not clear what the business opportunity is. So, Bob, I'm sorry, there is none. I just looked at your work. I saw it on LinkedIn and I was impressed. I wanted to get to know you. I'm sorry that didn't come through. No, that we had a 3.5 hour lunch. Bob was raised in New Jersey. I was raised on the south side of Chicago. I happen to be of Serbian descent. Bob happens to be of Jewish descent. And yet somehow we may as well be raised in the same house. We are like brothers. And we've become inseparable. Bob is actually the gentleman that came up with mild learning. Bob is the behaviorist. Bob calls me the visionary. I want to do this big thing. Bob has been doing very specific things. So, as an example, I think I can say this. How about I leave the university out, and that way I know I can say it. There was a university run medical center that was changing over from going to a transfusion center for chemotherapy to in home infusion. Their big concern was meeting the 70% on time infusion that they were seeing at their outpatient centers. Using Bob's technology and his years as a behaviorist, the messaging that they used with these folks, and keep in mind, you know this, but your listeners may not, you're going to take that, you're going to feel like not good after you take this stuff. You take it because it's going to save your life, but you dread taking it because it's going to make your life miserable for days or a week. And 90% of the people doing their infusions on time at home. His stuff works. So I look at Bob's work and say there's a bigger place that we can apply this. And we have, I won't, again, for confidentiality, we have just submitted a rural health RFP that does everything we are talking about here. We're working with Illinois to do the same. We're working in New York to do the same, and a few other states. The interesting thing is that every state has a Department of Health or Department of Health and Human Services. Every state has a land grant university. And not a single state in the union has the Department of Health and Human Services partnered with the research university to look for best care, best outcomes, to do health equity research, to look at the socioeconomic. Only in government would these two things not be meshed. Now, we have big companies like Epic, who are the largest provider of electronic health record services to the medical care world. They have a database that's incredibly valuable. I don't want anybody to misunderstand me. I'm as capitalistic and entrepreneurial as anybody you'll ever meet. But that data that they're collecting doesn't belong in the hands of the private sector. It belongs in the hands of a university with access allowed to it for the public good. And nobody is doing that. There is a program that Carle Illinois College of Medicine has put out called the Global Consortium. And they are collecting hundreds of millions of DNA records that will be shared across 18 countries, and I think it's 55 different learning institutions. That's the way this should be operated. I happen to be a U of I alum. I happen to love the fact that their new medical school is based on innovation. And if we are successful, there will be a database house at Carle Illinois College of Medicine that takes in all of the Medicare and Medicaid information from DHS, as well as the de-identified records of our virtual primary care practices that we set up using RHT funds. There's a way that a doctor who has practiced medicine for 20 years would query that database that is very different than the eyes of a student who just completed an advanced degree in artificial intelligence is going to query that database that now that they've started medical school. Mm-hmm. And I believe that getting these young eyes, these kids that have no built-in biases as to how to fix something medically, that's where the gains are going to come. Mm. That's where the breakthroughs will come from.
I am in complete agreement, and it's again, it's very impressive the network that you're putting together there, and getting all these minds on this problem, because it is it's a major, $1 trillion problem in our country, as you know. But thinking now, out a little bit, we've talked about some really cool innovation. Take us a little further. I mean, one of the things that was kind of intriguing to me when I looked at states like Alaska and Alabama and Kentucky, which had this major maternal health focus, and it's kind of scary to think that in the United States in 2026 we have certain maternal mortality rates that are equivalent to third world countries, which is by itself, that's a separate topic. But I noticed in some of these proposals was, kind of more, advanced stuff, telerobotic ultrasound and digital obstetric exams. And where are we going? I mean, what gets you excited? I mean, Mr. Musk is out there talking about, robots replacing doctors in a couple of years. Where are we headed? What would you like to see? What is the stuff that concerns you? What gets you excited for 2035, 2040 as we look out a little bit? Because this is clearly going to be evolving, and a lot of cool things are going to be coming into the table that obviously fit into what 360 is all about.
That is a phenomenal question. The biggest concern that we have is that AI is still immature.
Yeah.
And as AI, just a discussion with an AI bot can take you to very bad places. There are instances, well, there are lawsuits about kids being
Yeah.
told, yeah, good. Everything we do with our AI at this point in time is closed. We train it with the approved information, and the only information that that bot can get is the medically approved or approved by psychologists, psychiatrists, and limited. It's growing constantly. That will change quickly, but there is no way at this point in time that we would advocate for AI to make a medical decision. They want to throw you an opinion, that's great. They're not ready for decisions. On the other hand, one of the very interesting things is for any disease that you can list, there's a CPT code, a code for the insurance company to pay it. There's also an accompanying standard of care. In the United States, only 40% of the patients receive the designated standard of care. 40%. Now, if you happen to be a person that has the killer cocktail, you're diabetic, you're obese, you're hypertensive, but you also have cancer, or you have this, or you have that, there is no standard of care.
Yeah.
That's where AI can help, because we can take the AI standard of care for that heart condition or that particular cancer, and the other three, meld them all together by age from literally a closed book of knowledge, and generate a standard of care that the care coordinator at your virtual primary practice can oversee and make sure that the specialists are doing things right. You have a background in pharmacy. You get
Mm-hmm.
checked into the hospital. Your doctor, because you have an allergy or this or that, has carefully curated your medicines. When you go into the hospital, you get their equivalents. You don't get your medicine, you get the medicine that they have available at the hospital. That may or may not work as well as what you went in with. And
Mm-hmm.
when you leave with your new prescriptions, they're not coordinated with your primary care doctor. They don't know why your doctor wanted you to use this brand name instead of that generic.
Yeah.
And the patient doesn't have a clue. So, what do we see going forward? I do see the ability to get some type of ultrasound in a remote location. But our idea, because it is hard to get clinicians in remote areas, is, as an example, to take the device that we want to place in your home for diagnostics. We could place that at the agricultural extension office.
Mm-hmm.
With an hour or two of training, we can get a couple of people there trained. So that 80-year-old patient that can't quite figure out this gadget can walk into the agriculture extension office
Mm-hmm.
and have somebody there operate the piece of the equipment with a doctor on the other end. The operator doesn't need a medical degree. They simply need to know how to use rudimentary technology. So could we do that with an ultrasound? I'm sure there's a way to make that happen. And we
Mm-hmm.
can take non-medical professionals and turn them into operators of equipment with the medical professionals someplace else.
Mm-hmm.
And as we're talking about all this for the United States, anywhere that we placed a Starlink connection, we can deliver medical care into a third world country.
Yeah.
This is bigger than just us. It's
Yeah.
the way medicine needs to be practiced. And it won't just help us here, it will help literally billions of people.
Mm. You got me thinking of one other thing I just want to ask you about while we have you, and I really do appreciate your time. One of the data points I was looking at prior to our discussion was the fact that around 20% of the rural population in the United States is over 65 years of age. And it got me thinking a couple careers ago when I was working in the benefits area and thinking about we were not just providing services for employers of these self-funded organizations, but their retirees as well. And anything interesting happening? I mean, we talk a lot about healthcare in the home, aging in place, that whole area of important services for this silver economy, let's say, that is blossoming right now. But what are you thinking about? What are you doing at 360 in terms of the 65 plus population that wants to age in place, where these technologies clearly fit right in with what they're
You mean
interested in?
people like me?
And me soon.
uh, in the Florida area, in Miami and other areas of Florida, they have a number of different capitated programs where basically you take a patient, you're given a flat fee to try and keep them healthy, and you give away free donuts and a cup of coffee to try and get them to come in. You run a shuttle. What we need to do in the rural areas is reach out to these people virtually. Almost every grandparent knows how to operate Zoom so they can see their grandchildren. We need to do it virtually. There are not enough medical professionals. There are certainly not enough mental health professionals to staff all these areas. So we need to leverage them. And in a large picture way of looking at things, a lot of what we do with our digital therapeutics is the equivalent of the military expression. It's a force multiplier. We
Mhm.
need that health coach in the primary care office, but you can't always talk to the health coach, and the health coach can't be there 24/7. We can, and your homepage can be there for you 24/7. So part of it is a migration of technology with the older generation, who, for the most part, can operate the technology that they need to operate to be part of our ecosystem.
It's it's a very impressive set of tools you're bringing online. Peter, what should we be on the lookout for as far as we're in 2026 now? Anything coming up the first couple months of the year in terms of other milestones, other public facing stuff for the organization, conferences, talks, anything else that I missed while we have you today, please?
A couple of things. One thing that we didn't talk about, and I just want to make clear, there's an expression that is used at Microsoft called NIH. And no, it's not the National Institute of Health.
Hmm.
It's not
Yeah,
invented here, so
yeah.
it's no damn good. We don't believe that. We are agnostic in terms of equipment and software and everything else. If somebody has a better way of doing it, we just partner with them and incorporate it into our solution. Everybody wants to own the data. Well, we're not very smart. We're giving the data away to a university. So, with that in mind, there is a conference being held in Taipei. I believe it's April 10th, 11th, and 12th. And
Okay.
that will be the uh, Global Summit on AI and Innovation in Medicine. Uh,
Mhm.
I've been invited to speak there and really look forward to being there. It's a group of world leaders in the field, and it's a privilege that I'm being included there. We're beating the drum to help bureaucrats see beyond what they know.
Mm-hmm.
It's part of the issue with the whole Rural Health Transformation Grant. You're asking people to do something that's never been done before.
Mm-hmm.
Well, that's not their job. And to expect them to understand how to deploy is grossly unfair. So we've made ourselves available to anybody that wants to ask us for help or guidance. And if we can't provide that, we have partners and we have educators and we have doctors who are more than willing to help. Uh, I don't want to call it a movement. It's not going to be a movement. It's going to be leaders in innovation that adopt what we're doing. But by pooling those, that's where the real magic is going to happen. Just theoretically, we get the University of Rochester Medical School working with Carle, Illinois College of Medicine, working with Rutgers College of Medicine, and pool this knowledge and share the database. Where we start with the program that I've laid out to you won't be anywhere. We won't recognize what we're doing a year from now. Not because I'm a genius, but because we brought together a group of people and collectively we will be geniuses by sharing this information.
Absolutely. And yeah, again, this comes full circle back to where we started off in terms of your overall principle and how you have you worked over the years. And yeah, it's impressive. I look forward to continuing to watch how this evolves. And as you're saying, it's going to evolve quickly, and we're not going to recognize it probably in 2027. But yeah, I just I'm rooting you on. This has to be done, and really, really impressive work, Peter. I got to say, again, for everybody out there that is going to be listening to this episode of the show, or who will be watching on the YouTube channel. Again, you've been spending time with Peter Basica, founder and chairman of 360 Smarter Care. We will put the link to the organization in the show notes. But again, Peter, I really want to thank you for taking the time to walk us through everything you have going on there. Thank you for everything you do for patients. And as we like to say here on our show, thanks for helping to create a better tomorrow for people via the way you're developing and thinking about these technologies. Really, it's an awesome story, and I look forward to continuing to follow it.
Thank you so much for the platform that you provide and letting us be a small part of it.
We really appreciate it, and we'll help you spread the story.
Thank you.